just to show a little bit what it's felt like in terms of working in this area for a number of years. And moving forwards with trying to go forwards. So, leading a large program and trying to go into the future where you don't have things mapped out for you. So what I'll try and do is share for you some of the lessons learned, some of the things we've done in terms of building large telehealth programs. I'd like to start by just showing you just quickly a slide which gives you the kind of usual product development cycle in healthcare. It takes of the order of about 5 years to do some research and get the program sorted out. And then it can take anything up to 13 years to implement it. So the cycle of development in healthcare is very slow in terms of taking new innovation in generally. And in terms of some problems facing healthcare, we need to do things somewhat more quickly. The VA is interested in telehealth, or was interested in adopting telehealth for a number of reasons, which I said I'll share with you. But let me just start by just defining telehealth for you. You may already have had some of those definitions. And I loosely define it as using information and communications technologies to provide healthcare services, where patient and clinician or patient and provider are remote from one another. It's been around, so I'd just like to say to you, if you think you purchase technology which is just all very straightforward, does whatever it needs to do, the technologies are good, they're okay. Almost all of it is the human factors engineering around it and how you end up making this work. So lots of the issues you have rolling this out relate to the technology, so the selection, which is really important. Looking under the hood to be able to make sure it does what it's going to do is also extremely important. The second area, so let me just go back. I was going to talk more broadly, but given the audience, we'll just talk about it. So what we found by virtue of doing this is that we have a professional care coordinator, usually an RN or a social worker, who manages a panel of around about 100 to 150 patients. Now, the data we get from the home is data which is a day or 2 days old. And the intent is to capture those patients who are ending up on that slippery slide, that glide path, where they're going to get into trouble. We don't provide acute care in the home. As you know, there's no way organizations could do acute management of problems in the home. Somebody who's having an acute problem, they must end up contacting 911, go to the emergency room the normal route. This is for that group of patients who are the ones who are going to be on that slide down over 2 or 3 days. The person with heart failure, whose ankle's going to swell. We found when we've been implementing, certainly originally, there were some people, some localities that said, we won't do it this way, we'll do it our own way. We found situations where we didn't get a reduction in utilisation. In some instances, we got a 30 or 40% increase in utilisation. Because if you're monitoring people who don't get the information from home, you can deal with all sorts of variants can happen. So this isn't, as I said, just as simple as putting the technology in, it will feed you the information. You have to think how you're re-engineering care. I talked about inexorably these technologies are spreading, so this is all happening. This is just again to show, in the end, back to my point earlier, really if you're going to visit programs, if you're asking people about how they're doing them, do ask how many patients they manage. Because it tells you where in the growth curve they are. And in the end, the survival, I believe strongly, the only reason that programs that we've got have survived and grown is my absolutely single-mindedness that this has to end up providing care to patients. And once you've got a significant number of patients, you then have something which isn't going to go away again. Having said that, it's important that you think, at the beginning, are you in the business of just wanting to do a pilot, or are you really serious about changing healthcare? Because you do it in 2 different ways. If this is just a question, oh, this is an interesting pilot that's put in place, we'll do it while the grant funding lasts, and then we'll watch it wither and die. You can say, what really is the point of doing that? But I think what we're talking about in terms of technologies here are going to make the difference about how all of us in the room receive long-term care, or whether we receive long-term care. I think it's that fundamental in terms of how important this is that it gets done right. So if you don't get your passengers onto the plane, the fact is you aren't going to be flying. So keys to our success, I think again, slightly wider. This has also been taking a systems approach. I mean, healthcare is full of silos. Very simple example of taking that systems approach. I inherited, if you like, the home telehealth program when it had just been a pilot, and they said we would like to take this to scale. And in terms of taking it to scale, there was absolutely no process worked out. So it had been done for a couple of thousand patients, and all of the things were done by relationships. So, simple thing like how technology was delivered. So the technology was stored in a cupboard by a nurse, and then distributed, and the information kept in an access database. We don't go from one site to 153 sites by saying, okay, my plan to grow this program is let's find 153 cupboards around the country and make sure the 153 nurses with keys to that cupboard. And let's have 20 different access databases, none of which link together. So the way it's been possible, because as you grow something, you end up, that's where, when I mentioned the growth curve, things falling apart. As you grow something, you need to make sure the systems will cut in seamlessly and grow. We have a home devices and home equipment service that's run through our prosthetics service. So for me to get an agreement with them meant we had a national service in place for deliveries to the home, with abilities to prescribe the technology. It means I just leveraged what was there rather than trying to create another silo. And the costs of this, if you try and create it as a silo as opposed to systems and integrating it across, it would be impossible for us to have done it. Standardizing the clinical, the technology, and the business processes. The reason to do that is a very simple issue, is that physicians, nurses, and no other professionals that I know of at the moment are trained to do telehealth, home telehealth, or otherwise. No residencies or postgraduate training those things. Often people who want to do this to begin with, if you're not doing it already in the organisation, are those bright, innovative people who are good at doing new projects. Well, guess what happens a year down the road when you're beginning to, or 2 years down the road, when you want to put systems in place and organise it? Those people don't want to be around anymore. Also, those people, if your whole program is dependent on one individual who you've trained in one way, who has all the knowledge and they walk out the door, your program just does that. So, we developed a training centre for home telehealth, and basically have made sure we have a pool of staff that are there always to be able to, so we've never had an issue to staff training. 96% of that staff training is done virtually. So again, we're not having to bring people and fly them and train them. We can do it remotely via that kind of training. Because otherwise, something simple, absolutely fundamental, that's why many of these telehealth programs just fall. There were some enthusiasts and zealots that really wanted to do it. So you have to think how you're going to take it beyond just stage one. Standardized technology, architecture. None of the technologies for home telehealth are interoperable. So, if you've got, also, this is a small industry. Some of these companies are relatively small. We've had 2 go bankrupt. If you have your technology go bankrupt or technology not work, or let's say there was a recall, you could end up with a technology that doesn't interface with any other technology, and you're left with just so much junk in your home, your patients. So it's a small industry. So be very careful about thinking about that, and I'll talk about risk management later. Quality management, the Joint Commission. Now, the Joint Commission doesn't currently end up doing any inspections for telehealth. It's been too small. However, their tracer methodology means as they go round, when you get to any scale of size, as we do, they're constantly looking at telehealth programs. So we've developed an internal accreditation system, which is exactly the same as what the Joint Commission would do, to be able to make sure that how they review it, whether it's a home care program or hospital care program, how the technology is seen as a dual medical device or not. So all those kind of issues are really important to be able to think about how things forward. Now the Joint Commission will begin to do work in this area more formally, but at this moment in time, it's just something which is important. Aside from the fact just quality across the board is so important. I've mentioned training of staff, and it actually all begins with the patient. And strangely enough, though this is about technology, which is again why I say be suspicious of anybody who starts off just talking about the technology, making this work is almost all about relationships. It's about how you think what the relationship is you want with the patient or the client. How are you going to make that relationship work and how they fit into services. So, our clinical infrastructure, what we've done is develop operations manuals trying to standardize the clinical practice that's used around the technology. If you standardize how you do it, you can then standardize how you train. If you standardize how you train, you can do it on systems, so you can do it virtually and remotely. So it means you can do it just in time. We've got dedicated training resources. This conditions of participation is essentially our internal accreditation process. We have 21 regional units around the country. We happen to be in what's called VISN 22 here, which is one of them. Now, there's all sorts of variation in ours across every single healthcare organisation in the country. But what we've done is made it very clear. So we go around and we inspect each one of them every 2 years to be able to make sure they follow exactly how it needs to be done. So very clear conditions of participation have to be followed. And we've turned up all sorts of things over time, and it's not done to be punitive. Most importantly, it's really somewhere where we share learning and have really improved the program by virtue of doing it. And work groups. There are some people who say, this must be very easy to do in the VA, because you've got this command and control organisation who just tell people what to do. The organisation just told them to use these devices, and so it must be very easy. Nothing is further from the truth. Don't quote me widely in public, but it's an anarchic organisation like any one. We've got 153 medical centres. They all do things in totally different ways. And I showed, because it does feel like that, being at the controls of that aircraft. Well, the way I learn that we're not going to be heading down into the ground is not because I see the ground coming in front of me, because we work very closely with folks in the field. We get feedback. We want to know when something doesn't smell right at the very first stage. So the idea that you can get away in a room, think it all through, plan it out, implement it, and tell people what to do. You've got to have a very good idea of what you're doing and how you're doing it, but have to be very open in terms of that feedback. Because you want to hear from those folks out there in the field as soon as you know something's going to go wrong. Quick little thing which would have killed our programs very early on. For me, it's fundamentally how you code information. Because if you can't code what you're doing and quantify it in a routine, automated way, you haven't got your basic parameter. You don't know how many patients you've got. So it's critical. So early on, the program I inherited, which I had to grow, set up what's called a service line. So they developed their own little fiefdom. And they coded it in the way that coded all activity to that fiefdom. Worked well in one small area for 2,000 patients. As we grew it, we didn't provide money for staff. People had to re-engineer care and bring staff into it. So it wasn't this service line that's still fiefdom. It was done on the proposition that if cardiology wanted to use this, a cardiology clinic could end up using this technology. Guess what would happen if your cardiology clinic, you had to attribute all your workload to some fictitious service line that had nothing to do with it? Nobody would have done it. So it was picking up those kind of things that meant the coding could be changed, organized, they were credited with the coding, and it would work. It's one really fundamental example, but there are dozens and dozens where I owe what we're doing to the ability to create those systems and to listen so closely to what's going on. Standardized infrastructure for business, I said about coding, good business models, good use cases, funding streams. Now we had no funding stream whatsoever to begin with. So there was large amounts of grant money put out. It fitted in providing non-institutional care. But most of all, this worked clinically. So people adopted this mostly because they knew patients weren't being admitted to hospital. They knew it was reducing hospital admissions. Now for the first time after 10 years, we have got, well 10 years, 7 years, we have a dedicated funding stream through our allocation system where patients get credited. So we'll see a